Hi everyone, and welcome to the third episode of CBL, Case-Based Learning with Experts for this season. I'm Janice Lim, a member of the Academic and Research Bureau of the Malaysian Dental Students Association for the 2023 to 2024 tenure. We are now at Oasis Dental Specialist Publica, a practice specializing in periodontics and implants. Today we will be meeting with Dr. Philip Han, a specialist who is renowned in the field of periodontics. Aside from being a skilled periodontist, Dr. Philip Han is the co-founder and director of Oasis Dental Ara Damansara and Oasis Dental Specialist Publica. After graduating top of his class from Ames University in 2012, he went on to pursue Master of Periodontology in University of Malaya. He also holds MFDS and MPerio from the Royal College of Surgeons Edinburgh and England respectively, the latter of which he is the first Malaysian to do so. Come with me and let's meet our specialist of the day, Dr. Philip Han. I hear he has quite a few interesting cases for us. Good afternoon, Dr. Philip. Can you share with us about how your day has been? Has it been busy or has it been slow for you?
It's been a busy day, but I'm looking forward. Thanks for inviting me to join in this case-based learning discussion. So I'm stoked. Let's start.
That's great to hear. We are really excited to hear from you, and especially so after a little birdie told us that you have 3 cases for us today. And we're gonna surprise you with some quick fire questions after the case sharing, but he doesn't know that. Shall we get to the cases, Doctor?
Yes, let's get to it. So let me first introduce our first case. This lady, she came to my practice probably now three years ago. She was 25 years old when she first came, and she was referred by a clinic who was going to start braces for her. So her main concern was that her lower teeth were actually not aligned, and she felt that the gum swellings were getting larger and larger. So the main concern about her situation was that it's of course not aesthetic, but the referring dentist who referred her case over was more concerned about her gum condition. So when I first saw her, of course, her main aim was, Doc, how soon can I start braces? So of course, where I'm coming from is that I told her that first we need to get your situation stable before we can start braces. So that's where that was how I met Miss K. So Miss K is actually 25 years old. She is medically fit and healthy. She has an active lifestyle. But other than the fact that she noticed that her teeth were moving apart, she was not really a regular dental attendee at that point of time. So that's I think the brief introduction to the case.
So it sounds like she has a case of gingival hyperplasia and also periodontitis.
Yeah,
Right.
so what I would say is that it was enlargement at the beginning that when we saw her, but it was only after careful examination, that we could determine that it was periodontitis as well. And of course, that inflammation led to the enlargement that we saw.
May I know about what caused her gingival hyperplasia and also periodontitis? How did her symptoms actually progress to teeth displacement?
Okay, that's a very deep question to ask. I think if I were to go into detail, it would take probably the whole entire session. But just in a nutshell, Miss K actually had periodontitis, and as we know, periodontitis is actually a plaque-induced disease. So which means that with the presence of plaque in a person who's susceptible to periodontitis, that triggered the inflammation process. And because it was not caught earlier and it was allowed to progress, then that inflammation actually caused the gums to get larger and larger. And this enlargement led to a little bit of a hyperplastic change. I mean, on a side note, I think we have to understand that this does not happen to every individual. But unfortunately, in her case, the inflammation actually caused more collagen depositions, and that caused actually the spacing that we see, I think, in the photo between her lower incisors. So essentially, that was what happened.
You do mention that the management of this patient has been mainly non-surgical.
Yeah.
So could you share more about non-surgical management and how did it improve the conditions of this patient?
Right. I think the beauty about periodontitis, and it is a very complex disease, but the gold standard to treatment can be as simplistic as non-surgical therapy. And by non-surgical therapy, we are talking not just about what I can do for her, but essentially what she has to also do on her own. So this non-surgical therapy that we actually adopted for her, this case actually is a very, I would say, is one of the nicer case to showcase how just simple non-surgical therapy could address a problem. So non-surgical therapy in her case was actually, we started with a very detailed oral hygiene education session, which took probably, my sessions usually take between half an hour to 40 minutes. So we actually instructed her on how to actually maintain her oral hygiene. And during that same visit, we actually did a full mouth subgingival debridement, which essentially means that we clean below the gum level. And we were scraping against the root surfaces, a bit of the gum surfaces, and it was more of pocket debridement that we did. And I mean, credit has to be given to her, because what I do on the chair is just that for that 2 to 2 hour sessions.
Understood.
But following that was how actually she managed to maintain, and it's not a simple regime to follow. I think if you go through the different protocols, but she did a fantastic job. And non-surgical management was done in that one visit. She showed quite a fair bit of improvement during re-evaluation 6 to 8 weeks later. But subsequent to that, of course, the story doesn't end there.
Yeah.
So there was still some pockets. There were still some pockets that needed a little bit of re-instrumentation, which we did, and then subsequently she was stable. I think within 6 to 8 months. Yeah.
I see. That sounds really great for her.
Yeah.
Can you tell us a bit more about before the orthodontic treatment? How did the periodontal treatment and management actually have any effect on the alignment of the lower anterior?
Okay. I think if you're talking about alignment of teeth, I think periodontal treatment that we did for her in this situation mainly reduced the enlargement that you see in the photos. So that was to the extent that we saw in terms of improvement. But unfortunately, the malalignment or the displacement has already happened. So in her case, we did not see any spontaneous realignment of teeth. There are, there are cases in the literature. I've not seen that in my own patient pool, but there are cases in the literature where, with non-surgical therapy, the teeth that has been displaced actually come back into alignment. But we did not see that in her case, but we did see marked improvement in terms of like decrease in enlargement.
Okay. Could you bring us through your treatment plan for this patient and also the rationale behind it?
Okay. I think back to treatment planning, as you all would know, I think there are many protocols that you follow. Okay. Right now, there are many step phases. So for me, my rationale in terms of treatment plan is first to get the patient to understand what situation they are in. So the challenge for her was, she was more concerned of aesthetics. And it was like, when can I get my braces done? So we used that as a motivating factor for her. So that was always the price that she could attain. So rationale would be, in terms of treatment planning, I mean, to run you through it, my first phase was to make sure that she's medically fit and healthy. So systemically, she has to be okay. Habits-wise, she was a non-smoker, so that made things much easier. Then we went into a non-surgical phase, which is cost-related. And we know that the main cost was actually plaque and biofilm. So it was aimed at removing that. And then thirdly, I did preempt her for surgical therapy if needed. So that would be under more of a corrective problem. So what we foresee was that if, let's say, some of this enlargement do not go down, we might need to actually surgically remove this enlargement. And thank God we didn't need to do that. And then finally was actually to get her to understand that all this could recur, all this could trigger, and the fact that she has periodontitis actually makes her at risk of flare-ups throughout life. So we place her on supportive care, and then after that was the braces treatment, the price that she was looking for. Yeah.
Thank you for walking us through all the steps in this case and sharing your knowledge with us. I'm interested to hear about the second case that you have for us today.
The second case. So this second case is a working adult. He's 29. He was 29 when he was when I first saw him. Again, Mr. L, I think we call him Mr. L, his main motivation was to have braces again. So why was because he felt that his teeth were starting to flare, and he was starting to notice that there were discolorations in a few teeth in his mouth. So when he was first referred to me, the referring dentist's main concern was again, hey, in such a young individual, there is so much bone loss that they notice in the x-rays prior to placing on braces. So that's where I could help the patient. So again, for Mr. L's case, his main concern was when can I have braces done? Okay, but slightly different from Miss K previously, from the case previously. He was also concerned at the fact that he felt that some of his teeth were shaky. So he was asking me that, hey doc, isn't it only the elderly that would have shaky teeth? And I mean, that was when I came in and tell him that, hey, even the elderly should not have shaky teeth. When you have shaky teeth for no reason, it could be due to periodontitis. And that was how we got the ball rolling in discussing about that disease.
I heard that this second case is actually a multidisciplinary case, and I also hear that it involves periodontics and orthodontics as well as endodontics, right?
Yes, correct. So I would say that most of our cases in dentistry would require multidisciplinary kind of management. So this particular case, I think the focus, other than the fact that we have talked at great lengths about periodontitis.
Yes.
So in extreme cases, when the periodontal breakdown has gone all the way down to close to the apex of the tooth, that's where we could see that the tooth is shaky. So in some individuals, the tooth just dies away. Some individuals, they actually start to have symptoms like irreversible pulpitis. So in Mr. L's case, the two teeth that were very badly affected were the ones that were just in front of his third molars. And him being such a young individual, we were quite resistant to actually having them removed, the second molars, because they are helpful in eating. So that's where we started to realize that, hey, this is a perio-endo problem, and we will need to actually have cooperation also together with the other specialties.
Could you elaborate a little bit more on the perio-endo management for this patient, and particularly about how, doctor, you work together with the endodontist in management and treatment of Mr. L?
Mr. L's case, yeah. I think in this particular case, I worked together with his referring dentist, who is a general dentist, who did amazing endo treatments. I think it's evident from the X-ray that I think y'all will put up, that the endodontic treatment is a very vital part in managing perio-endo cases. So why we coin it perio-endo is because there is basically two pathways in which infections can happen. One is through the endodontic pathway or system. One is through the periodontal pathway. So when there is a combined problem, then we call it perio-endo. Previously, there were many classifications for this, and we can argue until the sun rises again on which comes first, which should be the main thing that we treat first. But in this situation, what we realized is that both teeth were not responding to vitality testing. And because they were non-vital anymore, they will not just respond to purely just periodontal treatment, the non-surgical part of it. And if I were to jump in and do a surgical management as well, again, because both teeth on each side were non-vital, they are not going to respond so well. So that's where we brought in the root canal treatment part, or the non-surgical endo part of things, and we did it together. So it was first root canal treatment being initiated, and when it was almost towards completion phase, we allow some time for the periodontium to recover slightly. Then we went in non-surgically, and then after that surgically.
Could you walk us through a little bit more in detail about the non-surgical and surgical approaches in terms of the periodontics and the endodontics part?
Right. I think the extra, I would say maybe what complicated matter a little bit more in this case is the fact that both his wisdom teeth, both his third molars were impacted.
Yeah.
And that made access into the pockets hard in terms of non-surgical cleaning. And at the same time, we do know that potentially it could cause also other problems.
Correct.
So with that in mind, we did non-surgical, like how I described for the first case. And then very closely after that, what we did was we decided to remove the third molars. And during the same visit that we removed the third molars, we actually did root surface debridement in an open manner because there was an open wound there.
I see.
And then we actually did kind of regeneration. So we did bone grafting, just distal to the 7, and then we closed everything up. So it was in a way surgical regeneration being done together with the removal of the aids. Yeah, so that's what I guess it was an interesting case actually. Yeah.
It does sound very interesting. So, doctor, to reiterate, the patient actually regained some bone structure at his 3-7 and 4-7 due to the bone grafting that you did instead of an osteoregeneration. Is that right?
Okay, I think if we were to put it to be very correct, it would be that we saw a bit of radiographic bone fill in the radiograph. So because we did not open up the wound again to test and see whether it's real bone, and we did not take a biopsy of the area, so I wouldn't say that it's 100% osteo. I cannot say that. Okay, but from the radiograph, I think it's quite clear that we have the increase in height in radiographic bone fill, and we can only hope. I mean, with the fact that we also have decrease in pockets over there, so we can hope that the regeneration is successful. Yeah.
Thank you for sharing with us
No,
about this interesting and complicated case. I truly enjoy seeing the importance, the potential, and the power of a multidisciplinary approach in the dental treatment, especially in this patient's case. And I'm sure that the audience shares my sentiments.
Yeah.
I wonder, doctor, what is your third case for us today? Are you saving the best for the last?
I think whether it's the best is very subjective. So this patient of mine is 45 years old. She was first referred to me by an orthodontist who was concerned that prior to orthodontics, her lower incisors, this patient's lower incisors, were a little bit too obviously seen. The root prominence were too obviously seen. So I think her main concern was that during movement, would it cause more recession? And so hence the reason the patient appeared on my chair, and I was able to run through options with her. So basically, this is the history of the patient.
Doctor, could you share more with us about the thin gingival phenotype as well as the thin labial plate? And what I mean is in terms of how is it like, how it affects the patient, and also possible complications of it.
I think most importantly is to understand the anatomy. Okay, so I think for us Asians, we generally, as a generalization, all of us have very thin gingivals as well as a thin labial plate enveloping our lower anteriors. When we talk about phenotype, right, this is I would say it's a relatively new term coined in periodontal terminology. It was first introduced in 2017 when there was a world classification workshop. So how we detect whether our gums are thin or not, the basic method would actually be to place a periodontal probe, okay, just at the pocket. And if we see the shadow of the probe, that would fall under a category of a thin phenotype. So the worry when we are thinking about tooth movement during braces would be that if, let's say, the gums are thin or there is a thin periodontal phenotype as well as a thin labial bone, if there is going to be a forward movement of root top, that is going to cause a little bit of recession. So hence the reason why the patient was on my chair in the first place. And I think the idea was, what can we do to prevent this? Or should we do some sort of a gum surgery or a grafting surgery to better prepare her for orthodontics? Or should we just proceed with orthodontics and then manage the problem later if it happens? So that was the big question.
Another question to you, doctor, is what are the clinical benefits of the phenotype modification surgery for such patients?
I think as its name implies, what we are trying to do is if a patient has a thin phenotype, and if we could modify it, change its character into something that is thicker, what we are hoping is that when there is movement in that direction, or even habits, say for example, to brushing in that area, the resistance to further recession would be controlled or diminished. So that would be one of the main rationale behind this sort of surgeries. Yeah.
So would you recommend phenotype modification surgery even to patients who will not be going through orthodontic treatment?
I think it boils down all to how there are so many factors that come into play with that. I think in the first place, if there are prominent root surfaces without any sort of recession, doing that sort of modification surgery might be an overprescription of treatment. But at the same time, I think we could also take into account um, some risk factors. Say, for example, if there is poor oral hygiene, if there is a high frenum pool, if there are certain practices that could predispose that patient to further recession or recession in the future, then probably introduction of this particular sort of management would be something that I think would benefit the patient. Yeah.
See, understood about that. So, doctor, did you harvest this patient's tissue from her palate?
Yes, yes. So the gold standard to um, gum grafts or gingival grafts would still be from the patient's own palate. So in this situation, we actually use a free gingival graft, which was harvested from her palate, and that was actually placed at the area that we were interested to actually thicken and bulk up. And subsequent to harvesting that gingival graft, we actually, rather than to leave it exposed and empty and to heal by secondary intention, we actually I actually placed something called a CGF, or concentrated growth factor, more to promote healing, quicker healing. And then she recovered quite well, quite fast as well. Yeah.
See, it's truly exhilarating to hear about such technologies being used in dentistry because you imagine that not so long ago, all of these technological advances, it's only part of science fiction and all those quirky research labs in movies. But nowadays, it has advanced so much that it can be done even in clinics.
Yes, correct.
I'm wondering, doctor, could you share more about the free gingival graft and how it is done in clinic? In particularly, how was the process like?
Okay. So I think to take you through the whole entire process, what we did, of course, I mean, consent and education, all that comes first. So that usually is like a 20-minute session, 30-minute session before I even start the surgery. In this particular patient's case, what we did before actually entering her mouth was to first draw her blood. So we drew the blood and we spin it down to a certain at a certain RPM on our centrifuge to harvest the CGF that was going to be later placed on the palate. Subsequently, actually, what I did was prepare the area that was going to receive the graft. So the surgical management to it was actually getting the we call it a split thickness flap. So we had to we could not raise the entire flap because we still want a little bit of connective tissue on the surface to receive a graft. So after preparing the area down here, the recipient side, I went to her palate and harvested a free gingival graft. So the free gingival graft, essentially, we do know that on the palate, the tissues, there's a hard palate and there's the soft palate. So at the hard palate, it's going to be a little bit more keratinized. So there are certain landmarks that we have to avoid and or follow. The free gingival graft was basically measured prior, or rather the dimensions was measured prior, and later I went to the palate and harvested a piece of that. Okay, and subsequently I placed the CGF up there on the palate. We sutured it down, and the bulk of the surgical time was actually suturing the free gingival graft on the recipient side. So that I'm maybe a little bit OCD. So I wanted it to be sitting well, and I think principles to healing or success was actually is definitely how stable this graft is, and hence the reason why sutures take so long. Yeah, suturing takes so long in this case. Yeah.
See, so the role that the CGF actually played in the management of this patient is to aid the healing on her hard palate. But what about for the labial side?
Okay. So yes, you're right. So the CGF in this situation was more for promotion of healing on the open wound that we created on the palate. For the labia area, it was just free gingival graft, and healing was naturally that way. So we did not place any CGF on that area because the free gingival, sorry, the FGG, the outermost layer is actually the epithelial layer. So the moment it was placed on, and the bottom part apical to it, I think you see from the photo, apical to it was left to heal in through secondary intention. And I think healing was, I mean, if you follow what we know about healing, a lot of epithelialization and healing takes place within the first 5 to even 7 days.
I have a question to you, Doctor, to hear about your views and opinions. So can you share with us about your views on balancing aesthetics and functionality in dentistry, especially in such a case where it involves the free gingival graft? How do you find that balance, and is aesthetic or functionality more important to you?
I guess I can understand why you're asking this question, because the outcome of this case, I would say it's pleasing to the eye of some, and it might not be pleasing to the eye of others, because the bulk that we achieve with free gingival graft, some might see it as unaesthetic. I think to come back to your question, when is aesthetics and when is functionality important? I would say that both are. When do I prioritize one over the other? It really depends on whether or not I am able to actually bring about or achieve both in one surgery. So we talked so much about FGG just now. There is also something else called the connective tissue graft, the CTG. So with certain cases in similar situations, sometimes what I do is I actually open up an entire flap, place the CTG in place, and then close it all up again. And we get the bulk that we are hoping to get without the pinkish color or the enlargement that we see with FGG. But why was I was in a sense restricted by the fact that existing periodontal phenotype in this particular situation was so thin that the moment if I were to open the flap, it would just tear, and I would not be able to achieve that. So in this situation, hence the reason why we use the FGG rather than the CTG. So just to answer your question, both are important. If I'm able to do and achieve both in one surgery, that would be great. Sometimes we use a second surgery to try to achieve aesthetics later on.
I see.
Yeah. So in this particular situation, because the main concern was that there was going to be further recession, and this was what the orthodontist wanted as well. So hence the reason we chose this method.
I must say, Doctor, the cases that you've brought to us today have been really interesting and really insightful. And the climax build-up really has me hooked.
Oh.
Thank you so much for taking your time to share with us and to present this case to us, for us to have an opportunity to learn from you and hear from you. And I believe that this brings us to the end of our CBL session today. So, no, actually, I'm joking.
What?
Actually, Dr. Philip, this brings us to our round of rapid fire questions.
Okay.
Yeah, I hope you're ready because we have some questions for you.
All right.
Okay, so the game rules are to answer the following questions as fast as you can.
Okay.
So don't think and just speak whatever comes to mind.
Right.
Okay,
I'll try my best.
Okay. So first question, what was your childhood dream career and why?
Okay, this is going to be very easy. I always wanted to be a pilot.
I see.
It was always, my dream was always to be a pilot. I love aeroplanes and I love the idea of flying. So hence the reason, So it was always to be a pilot.
I see. Can you share with us your favorite dental or perio joke?
Oh dear, this is bad. This is tough. No, I heard this from someone just recently. So let me ask you a question. What is a
Okay.
periodontist's favorite candy?
Lollipops?
No, gummy bears.
Gummy bears for gums.
Gums.
I see.
Yeah.
Okay. Moving on to the
Mhm.
third question. What is your favorite downtime activity?
I love football, and so I still play that regularly. So
see.
that's my favorite downtime activity.
That's very active of you.
Yeah.
Another question. What was your favorite trip like?
Sorry,
What was your favorite trip like?
what was my favorite trip like?
Yes.
I would say probably the most memorable one was one that I went just recently in December. Trip, right? You said TRIP,
Yes,
right? Trip.
correct.
Okay, all right. So this was to the French Alps. So we actually got a car and then we drove around, and it's surrounded by snow and all that. So that was like, I think, one of the most memorable ones. Yeah, that I had.
see.
Yeah.
That sounds really, really nice.
Yeah,
Must have been really scenic.
it was. It was. Yeah, take me there back there now. Yeah.
Do you have a secret talent, doctor? And what is it?
Huh. I think my talent will not be a secret anymore if I tell you about it.
Evasion, I see, doctor.
Evasion, yes. Flip the fifth. Yeah.
Okay, I see. Next question. What is your dream retirement like?
I think it would be being able to travel whenever I want to. I don't think I will ever give up dentistry completely. I think dream retirement would still be being able to come in when I want to, probably maybe one afternoon a day, and then being able to travel wherever I want to with my loved ones. Yeah.
I see. That sounds really, really nice to
Yeah.
have in the older age.
Yeah, yeah.
Do you have a favorite animal?
My dog.
Your
My
dog?
dog. Yeah, yeah. She's Zoe. She's a pom. Yeah, so she's my favorite animal at this point of time. Yeah.
I see a little ball of fluff.
Yes, yes, yes. She's a darling. Yeah.
I have a question, doctor.
Mhm.
Do you prefer writing with pen or pencil?
Pen.
Pen.
Mm.
See. Will you eat 2 packs of Samyang spicy ramen without any water for 5K?
No, no, not worth it. If I was 5 years younger, I might answer yes, but no, no.
Okay.
Yeah.
Choose something that you have to give up for life. Flossing or brushing?
Neither. Neither.
If you're forced to choose,
Flossing then.
flossing. You
Yeah.
will keep brushing.
I'll keep brushing. Because I will have less and less teeth, and it might be easier. I don't know how to answer this. Yeah.
So how do you feel right now, doctor? Is your heart beating very fast for
Yes,
the rapid
yes.
fire question?
Thanks for getting my heart rate up.
Thank you for humoring us with the rapid fire
It's my pleasure.
questions.
My pleasure.
And especially for all the cases that you have shown with us.
Yeah,
shown
it's
us
truly my
today.
pleasure. Thanks for coming and chatting with me as well.
It was a very great
Mhm.
opportunity to hear about your experience and
Mhm.
also to get to know you better as a person.
Likewise, likewise.
Thank you for the case today, doctor.
Thank you, Janice. Thank you.